All right, I'm back. Plenary session, virtual edition. I'm joined by the great Dan Morgan. Dan Morgan, professor of medicine, University of Maryland. He's a practicing infectious disease doctor. He is a infection control expert. So he's got all the credentials. He's also a self-professed liberal. And that's going to play in because of some of the interesting things you've been tweeting. Dan, it's a pleasure to have you here.
Great to be talking with you again, Vinay.
We're going to be talking about two things. I think maybe we'll talk for 15 minutes or so about COVID-19, and then we'll talk about your paper in medical decision-making, which is always going to be in style. COVID-19 won't be in style forever. So here's my question for you, Dan. If you're on the campus of Brown University and you're a 20-year-old college student, you just got a rude awakening. You just got, you've been spitting in tubes, and that spit is no good because they found some SARS-CoV-2. And so my understanding is that, they shut down the whole campus. You have to eat outside. You're only allowed to hang out with 3 people. Other colleges, you have to wear the mask outside, as we know, the prime place where cloth masks work, right? Obviously, so cloth masks, obviously they work, even though Bangladesh, they didn't work. And obviously they work outside, even though that's not the place where COVID spreads. Okay, so here's my question to you. This is going on at universities. They are really, martial law. And then, you go out any city, people are in restaurants, 50 people, 100 people, no mask, indoors, dining. Nobody else is doing this. What is the goal? I'm just what are we trying to accomplish now? Can we get rid of this virus forever? What are we doing?
I mean, that's the big question, really, is what are we doing? And I'm not sure that people have the same answer, or that people have really thought about what is the end goal of this. Because, I mean, it seems if you really ask anyone, they say, well, the virus will never be gone. It's just we're trying to wait for it to become endemic, which I'm not sure exactly when we decide that's happened. But, I mean, it seems like it's pretty much happened. It's just sort of at higher or lower levels of endemic state right now.
So I guess my question, though, is I don't know, is Brown's policy serve a purpose? Like, what does it actually even do? Does it help anyone at Brown? They're all 20-year-old kids.
I mean, I was just talking to a parent of a Brown child, a colleague of ours, Debbie Korenstein. I don't think she'd mind me saying. And she and her husband, who are ID docs, were eating with her son, and they were saying they thought it was crazy to be testing weekly because you have it's 99% vaccinated population. It's a young population. It's a cold more than a severe disease. But the weekly testing is going to mean that you don't go to school.
Yeah.
And I've heard that some colleges, not Brown, I guess, but some that colleagues of mine advise on, parents have decided they won't let their kid be quarantined, and or else they won't pay for it.
Really?
And colleges are not quarantining people at some high-end colleges.
I see. Interesting. I mean, I don't know what any of this, I think I do know what happened. I think what happened is a lot of people who put out modeling papers are getting paid by these companies, like whatever, all these companies that are selling these tests, and the companies want to sell the test. And so they go to colleges and they say, look, if you don't do our testing, you're going to be knee deep in hospitalized kids, and you don't want that. And so of course the hospital or the college gets scared. It's run by bureaucrats who don't know anything. And, they capitulate to this kind of tactics. And I don't know. I don't think we're helping anybody, and I think we're kind of messing up these kids' youth.
I mean, I think it's definitely a huge distraction. I mean, I see this as I just put my pre-K child into a new school, which is a highly liberal school, and they do all the college stuff, weekly testing, et cetera, and outdoor masking, and I think it's just a trap that people fall into. I mean, I do think some people have undisclosed conflicts of interest, but I do think also the biggest one is just, I think humans want to be doing something. People are kind of scared, especially if they, are on certain end of the political spectrum. And so they want to see that something's happening. And so, get out your thermometers, get out, your mask, and all these things that appear like you're trying. And even, and don't really look for the evidence. Like, it just naturally must work. I think, that narrative carries a lot of weight.
Yeah. Don't just stand there, do something. Yeah. I think that's the classic mantra. That's, one of the curse of being a human being, that you're just going to keep trying things that don't work, don't make a lot of sense. I mean, I honestly think that here's my thoughts on this issue. I think in the next 7 to 10 years, there is a 100% probability you're going to get SARS-CoV-2. Now, you don't want to get it if you haven't had a few doses of vaccine in yet, if you're an older adult. Even by older, I mean, even my age, 38, you don't want to hit it. You don't want to meet it without a few doses. I got a few doses in me. Both of my arms have blown up before, I've gotten a few doses in me. So I'm going to meet it on the best terms I can meet it on. And whether I meet it this year or next year or 4 years from now or 7 years from now really don't matter too much to me. But that's the date. I got a date with SARS-CoV-2, whether I want to have it or not. That's the reality.
I think that's true. And you may not even need to know if you met it or not.
That's right.
You don't need to get tested necessarily to to know it happened and stay home for a few days or something.
I don't know how many times I've met rhino and coronavirus in the past. I don't para-influenza. I don't know if I've met it, but I'm sure I've met it. I don't know, because you don't need to test for all these things. Yeah, I think that's the reality. And then the other thing that I was in a lot of hot water about was, I said controversially that there were no cluster randomized trials of masking school children in this pandemic, or to be my knowledge, at any time in human history. And that's a factually true statement. It's a technically true statement that people want to dance around. But I just saw Ireland today said we're not going to mask anyone under 13. UK never mask anyone under 12. I mean, we have to grapple with the fact that we are doing something that no one else is doing, which is we're masking the two. And by the way, I always wonder why they didn't why don't they go to one? What happened magic? What happens when you turn two? Suddenly they got you with the claw. And then we have to put them in the mask that actually doesn't work. That's what, instead of the surgical mask, because obviously we don't have surgical masks in their size, and obviously we don't have data that supports that, but we put them in the cloth mask that didn't work in Bangladesh. I mean, what am I to think? This is really thoughts. You're an ID doctor. You're an infection control. You like to control infections. That's your job.
I mean, there's always a bit of a conflict internally, I guess, for me, because my day job is really to sort of, enact policies that are passed along by OSHA, CDC, whoever else, that tend to be quite conservative, and the debate is more N95 mask versus surgical mask, not, mask
Yeah.
or not.
Yeah.
And, but I mean, I think, middle ground often is very helpful, and sort of like trying to kind of gradually move in one direction or another and address fears. But I mean, I do think the European experience is key, and I think it shocks Americans to hear that countries that are very similar and that had similar, rates of COVID just didn't do that, and didn't do it last year often, and had schools open during the pandemic before a vaccine was available. And I think that's just hard to conceive of. I mean, I think it really does emphasize something that hopefully we talk about later with probability, that like people tend to be all or nothing thinkers. And it's sort of like, the vaccine's good, everyone should have it. I want my 5-year-old to have it, without knowing if the data shows it's good, and or masks are good, and therefore we should be putting them on as much as we can. Versus the kind of nuanced version, which is, masks are probably good in some situations. And, when I go see a patient with COVID, I'm putting on my mask, and I want to, and if I'm in a, crowded room of a bunch of people I don't know, and some are coughing, I want a mask on. Probably N95 would be good then. But like that variation in risk is really hard to assess, and to say like, well, I'm outside or I'm in my car by myself, there's no reason to wear a mask, which of course you see a lot of that.
Yeah. I mean, I think you're hitting the nail on the head. It's hard to get that nuance, and it's also hard to like point out. The other thing I think people have a hard time grasping is they're like, well, it's the classic reductionist mechanistic thing. Like, yeah, this should catch something, so it's better than nothing always. But the reality is like, yeah, true, theoretically, sure. But when you start to drift into certain age groups where compliance goes low, where mucus production goes up, where saliva goes up, where they take it off to make a big nap during the day. I mean, at some point, it's really just a distraction. And obviously, it's taken on biblical proportions because of the politics of it. But let me come to the one thing you said that I wanted to talk about for a second: the vaccines. I guess I haven't said this too much, but it kind of troubles me in one sense, Dan, which is like, when you run randomized trials for a reason, which is like, you don't know what you might get. You might get a win, you might not get a win. But the way we talk about kids 5 to 11 vaccines, it's like we have assumed it's a win and we're going to go forward. And no matter what the results are, in which case there's two questions that follow. Like, if you've decided that, then you shouldn't have even done the randomized trial. You're just delaying the inevitable. Like, you're going to approve it anyway, no matter what you find. So why even do the study? It's not going to change you. But also it's kind of, I think it's a problem. And, like, there really is something that could come in that trial that would make you rethink that. Fair to say.
Yeah. I mean, I think, I mean, this has been one of the interesting sort of Twitter things that I tune into here or there and don't really say much about. I mean, certainly like myocarditis being, a rare but bad side effect in young men, and the strokes with the Johnson
Yeah.
vaccine in younger women,
Victim.
and certainly these are rare events. But if you start talking about people who have very, very rare COVID events, it starts to seem hard to prove there's a benefit. And I know some of my colleagues have said, I think as long as it's not dangerous for kids, which that's a relative term,
Right.
we should just be doing it so that schools stay open. Which I've often thought that's probably trying to fix a problem in our policy with forcing a vaccine without great evidence. And it's hard to talk openly about vaccines, and some are great and some are bad, and some actually, and most may be good in some places and and not very helpful in others.
So well put. I mean, like, I agree. We want schools to stay open. And then people say, like, that's why we mask. And I was like, well, the whole point I'm trying to make is, like, if masking doesn't slow spread, then that's not actually keeping it open, right? Like, and if they're like, kids are in the hospital. I was like, yeah, but if this masking like doesn't work, then like they're just gonna keep being in the hospital, and like you're not helping the problem. So like, why do we want to do things that don't work? And then similarly for like the keeping schools open, like the best thing you can do to keep schools open is like, don't do blind surveillance. Don't keep collecting everyone's spit, and it will stay open more than if you collect spit. And the whole point of collecting spit is theoretically you decrease the number of people in the hospital somewhere, but you have no clue if that's true or not. All you do know is you are disrupting society after having disrupted it for a year for no good reason.
Yeah, I mean, I think I remember someone, it's funny, I hear complaints about you, like, well, I was with him, but he pissed me off with this thing or that thing, but I think one of them related to, oh shit, where was I going? I don't know, is relating to this issue where I think, you had a good point. Oh, and they were saying, like, what will Vinay be doing in 10 years? Will he be doing randomized trials of kids in school? And I would say, I mean, I think this is all pretty consistent with what your arguments have been all along. They haven't related to schools or anything else, but it's just like more scientific, skeptical side about what we do or don't know versus let's do things and then, based upon theoretical mechanisms, and then, worry about if they work later.
Yeah, I mean, I think people are like, oh, you're going in a different direction. I was like, my direction's always the same. Here's my direction. You can always do things on a short-term basis in the moment of panic. Sure, I'll give you it. I didn't say a peep about it first year. I was very quiet, whisper quiet. 1 year, I give you 1 year grace period. But then I come at you like a ton of bricks, because here's why. Then it starts continuing indefinitely in perpetuity. They're going to keep reinstituting it every time there's a flu season, a year from now, 4 years from now, 5 years. They're just going to keep reinstituting it. And at that point, the question is, you're going to keep doing it for the rest of my life. And you got to generate credible data. The next thing I'd say is like, many things are plausible. You and I both agree. Many things are plausible. Most plausible things don't work. And that's what people outside of biomedicine don't know. Most exquisitely plausible things just do not work in real life. They don't work. You can talk about your bug trial, but most really, really plausible things don't work. That's why the pharmaceutical company is striking out more than they're hitting. Okay. And then the third thing is people can deceive themselves into thinking things work. This has always been my worldview for 10 years. It's still my worldview. You can mask the kids for 3 months. Sure. You're getting to 18-month mark. Come on. And then the other thing, what is like nails on the chalkboard for me, Dan Morgan, is when people say like, this is unequivocally been proven by science. Oh, nails. I was like, no, it hasn't. God damn it. No, you're wrong. I mean, come on. What do you think? I'm an idiot? I know that you haven't proven that. What are you talking about? I'm not an idiot.
I mean, it's really interesting to see people with sort of how they have this different values applied just depending on the subject matter too. I mean, all this, skepticism around ivermectin. I think someone at the swimming pool was like, oh, I hear people are giving this horse medicine, to take COVID, and it doesn't work. And which I completely agree. Don't give ivermectin for COVID.
Yeah, I know, me too. Yeah. No.
So like I'm with you there, but then but we're in the same setting where it's like there's all these other things that people are still doing that make no sense either, and the people who are anti-ivermectin.
I saw somebody say like they're like about ivermectin. They're like, we just shouldn't do things that are only supported by bad observational studies without randomized trials proving benefit, like ivermectin. I was like, that applies to a few other things too, but a few other things it applies to. You're missing the point. I agree with that. Like my pretest probability for ivermectin was like hydroxychloroquine. It's in the toilet. And
Yeah.
it's not even these two. Remdesivir, my pretest probability is in the toilet. Tossi, Dex, everything is low because pretest probability for drugs is really low. We're going to talk about your probability paper now. And the purpose of trials is to prove to me it actually does work. We did have success with, actually, I think remdesivir, the data is actually kind of.
It seems like it's kind of getting worse as we go along.
Yeah, I think it's not so good. But steroids, the data is good.
Yeah, and I thought they wouldn't work because steroids seem to never work. But
I know
that seems like the best thing we got.
What else has turned out? Tossi, are you a believer in Tossi? The trials are kind of equivocal too in small sample size.
I mean, I've been pretty skeptical, but I've given it to some people.
What about the blood thinners? These if you're severely ill, they don't work. There's like this little pocket that'll work. The blood thinner works if you maximum dose anticoagulation.
I mean, I've been curious. I don't know what people are doing with that. I mean, I was those New England Journal trials with the Bayesian analysis were really kind of confusing to read and see if they worked or not. And yeah, I mean, I'm skeptical that they work, and I'm wondering how they've been incorporated. I haven't really seen evidence one way or another.
Yeah. So I mean, I don't know. I've heard. I mean, at the end of the day, I think the core lessons are the same, which is, now we're going to talk about your paper. The core lessons are like, human beings have lived for, thousands of years where we feel like we can do things to combat the forces of nature around us. And most of what we feel like we can do, we can tell ourselves a great story for why it ought to do what we want to do. And then we can also pair it with morality to encourage our colleagues to say, like, we ought to do this because it's the right thing. It's the virtuous thing to do. Most of those things we've done for thousands of years have not actually done whatever we thought they would. They didn't make it rain more in a drought. They didn't make plagues go away. They didn't make us healthier when we have heart failure. And the way to separate it was an invention in the 1940s, the randomized control trial. It's the real only good way to separate your hope and hype from truth. And that's always been my worldview. It will always be my worldview. I'll give you a grace period for extenuating circumstances, but it doesn't run forever. And that's my philosophy on life. And it's going to be, the same consistent philosophy.
Yeah, no, I mean, I think I'm mostly with you. And I mean, and especially just being skeptical of the theoretical arguments.
I know, come on.
I mean, I really
so
think
much.
that in medical school, it's not so clear that that's important versus, actually like real life data and especially randomized trial real life data.
Yeah, and human behavior is fickle. People behave in different ways.
Yeah.
So let's talk about your paper. I mean, I think this is a good prelude to your paper, actually, because your paper is getting at, like, I don't know, the places of medical decision making where rationality and intuition can uncouple. Is that fair to say?
Yeah, I mean, I think, let's see, and I guess there's sort of two papers that are really similar, but
okay.
probably the first one.
Which one do you want to start with? The first one is about test probability, and the second was about treatment.
Yeah, exactly. That seems like.
Let's talk about the treatment first, because that's my favorite place in medicine.
All right, treatment. Yeah, this is the one that JAMA said no, so it got into JAMA no.
That's what I call it, JAMA Network Open, JAMA no.
I mean, I've heard an editor say that too, so it's probably not off limits. It's a good journal, right?
It is a good journal. I do like it.
And it's great that people confuse it with JAMA when they're like, I saw your paper.
Yeah, in JAMA. I was like, yeah.
In JAMA. And you're like, yeah, JAMA, no.
JAMA, no.
No. So, I mean, it's a great journal, and they did a great job of really building an open access journal that has a lot of good papers in it.
So let's talk about, what's the title? I'm going to pull it up.
Yeah, so this is a clinician conceptualization of the benefits of treatments for individual patients.
Whoa.
A little dry.
That's not, you got to work on the title, Dan Morgan. I got your JAMA IM paper up. Okay. So Dan Morgan, JAMA Network Open. Clinician assessment. What does it say it again?
Oh, so the one on treatment, I mean, and part of this is, I think, like what we felt like reviewers would allow us to say, versus like how we would translate it to the general public maybe, but it was clinician conceptualization of the benefits of treatments for individual patients.
Okay. So walk me through it. What is this? What is this paper doing? I
I
got
mean,
it.
so your reaction to this paper would probably be like Victor Montori's or others when we were talking about the idea, like, well, you know what it's going to show, right? Like doctors aren't going to know it, and why do you want to show that? um, and I mean, to me, this was it seemed like there was this reality that we just weren't we didn't accept and we weren't really aware of that really shapes a lot of our decision making. And so that was the goal of this, and is really to try to translate the way we approach, I guess, clinical trials with treatments, where we try to look at the effect size and how many patients will be treated, will benefit from treatment, and to see how that's translated to day-to-day clinical decisions. And certainly we had a bias thinking that probably doctors didn't do this. But a lot of the work before was kind of theoretical. People would ask like math questions or single one-off type examples that didn't really put their finger on the problem quite as well as we thought we could. So that was the reason we wanted to have these little scenarios in a survey of doctors across 8 states.
Okay, this is good. And I like these questions, and I think it's a clever way to do it. But before we get into it, like maybe we should just say philosophically, I'm going to tell you what I think, and you tell me if you disagree. Like, I don't know, if there's 100 things you can do as a doctor and you have to prioritize what to do, what are the things you do? And I would say you sort them by absolute risk reductions, and you do the things with the biggest absolute risk reductions, and then the things with the smallest absolute risk reductions. And I think the fallacy sometimes people make is they think baseline risk equals absolute risk reduction. But there are lots of conditions where baseline risk is really high, but you can't do much about it. You can't do much about it. So it's really the thing that you can do the most. Your delta is the biggest. What are your thoughts? You agree?
I mean, I agree. And I, just add, of course, trying to have, compare similar outcomes, of course.
Of course, right. Yeah. We have to have the same coin.
More important outcomes.
Yeah. Like life or death rather than how many, I don't know, what's your A1C at the third decimal point, right? Yeah.
I mean, and I think, certainly in residency, I feel like I saw this where you would, see clinic patients come in and they'd be on 25 medications that would all be in a bag and they weren't taking them. But, there were probably like 3 medications. If they would agree to take 3 reliably, you could probably choose the 3 that would be best for them and that would have a much bigger impact, like someone on HIV meds who's not taking that, but they take their daily aspirin or something, it certainly would be, getting the worst of the medicine they have.
Yeah, I think we suffer from that a lot. Polypharmacy and taking drugs that have proven they work in some key groups and extrapolating it to every single person.
Yeah, I think that latter part is another one that's hard for people to grasp. Like something, just because something works doesn't mean it's good in all patients. And certainly I think a lot of the marginal benefits are when you look at mild disease and try to really expand indications.
I see. So I'm looking at your paper now. I see figure 1, clinician estimates of likelihood of disease outcomes and benefits of treatment. And you've got warfarin for stroke prevention, antihypertensive therapy for cardiovascular events, bisphosphonates for osteoporosis, and statins for CV events. And on the left, you have a density plot of what people have actually told you. And then you've put in orange what the scientific chance of disease outcomes is to show, I guess, quote unquote, the right answer. And you show that, like, sometimes a chunk of the density is in the right answer, but a lot of the times, a lot of the density is outside the right answer. And then in the right set of panes, what you do is you have what doctors estimate the benefit to be in terms of, I believe these are absolute risk reductions, and you show the right answer as well. I wonder if you might walk through, like, what are we looking at here, and what do you think we're seeing?
Yeah, so I think you did a good job of describing this figure 1, and
I even have a better idea. I can even show the figure. Okay, go, keep talking. I'm going to
all
show
right.
the there we go. Now everyone can see it.
All right. So, so on the left side is the chance of having a bad outcome, which, if you're doing a trial, certainly this is how you choose your population, right? Or you choose your effect, the size of the number of people you need to enroll to show a certain amount of difference. Is how often is something going to happen? And then on the right, how much can you improve that? And one of the tricky parts of this is the way we ask the question. I think it left reviewers saying there was some disagreement, like, are people certain that you're asking absolute risk reduction or relative risk reduction? Because we said, what is the chance that warfarin will prevent Mr. Miller from having a stroke in the next year?
I see.
So we
Vaguely
didn't say
worded.
like, what's the relative risk
So,
or
but what
absolute
you're
risk?
showing on the right is that either way you slice it, look at all these people. They're going crazy. Too
Yeah.
enthusiastic.
Yeah. And so this picture, I mean, just is like a completely perfect distribution from 0 to 100%. And I mean, and we were really trying to phrase the question asking for absolute risk reduction, because
Sure.
if you're talking to somebody and, and there's a 1 in 100, the absolute risk reduction is 1%. Well, really, that's like a 1% chance of benefiting them.
Sure.
But we didn't pin them down by the number with the exact terms. So we tried to present both and really highlight that people didn't do a good job of either, although absolute risk reduction is the right way to talk about this.
Right. Okay. So I guess the way I interpret this is green is right answer. Blue is like an acceptable misunderstanding answer. But either way, the density is like, why do they think warfarin works so good for stroke? What's going on here? Why are they so eager? Why are they so happy for it's Coumadin, for Christ's sakes? It's not even dabigatran.
Yeah. I mean, I think the relative risk reduction, people sort of have like 50% in mind, and I mean, I really don't know beyond that. And of course, the problem with warfarin is that the relative risk has to be applied to the absolute risk. And in low risk patients, really don't have much of a chance of stroke, and then can't have much of a chance of benefit.
That's why we, for certain Chad's too vast, we don't even do it. But one thing I find, Dan Morgan, about this anticoagulation, that's kind of a pet peeve of mine, is that, whatever your indication is for anticoagulation, there is a non-zero probability you will have a clot again. There ain't no anticoagulation that brings it to zero. And eventually, inevitably, with large numbers, you will get such clots. And then you'll consult the hematologist, and the hematologist will go in. And inevitably, many people will say, switch them. If they're on rivaroxaban, go to apixaban. If you're on apixaban, go to enoxaparin. And they call it like, failure on rivaroxaban, and all this language. And part of me is like, I don't know, you're doing all this stuff and you probably still have like the exact same probability of subsequent embolic event as you did before. You're just switching pills and making it confusing, but you feel like you're doing something, which is another, example, right?
Yeah, I mean, that's that it's interesting to hear the hematology perspective, because I mean, that makes complete sense to me, that no evidence behind it, but just kind of makes sense. Let's just try switching to something else.
Switch.
And and 95% of the time they won't have another event, so it looks like you did the right thing.
Right. It looks like you did the right thing. And if it has an event, then you switch again and you keep going around the merry-go-round. So the antihypertensive question, what are we talking about here? So this, I mean, if the right answer is a few percentage points, this is an older person with high blood pressure?
So, I mean, so we tried to choose these scenarios with the idea that we wanted to get at things where there was shared decision making was often recommended. So these are ones where the guidelines weren't completely clear, or they talked about talking with the patient and deciding the risk versus benefits, and thinking this is where doctors should need to know how to talk about these things. Of course, we know that shared decision making is rarely actually done. And so the way we ask the question, so the hypertension one, of course, there's a lot of nuance, because if you had a high blood pressure of 200, a systolic blood pressure of 200, I think there wouldn't be much disagreement that, people benefit from treatment and you should do it.
And you're over 75, like older you are, higher the blood pressure, not so good.
Yeah, so this one though was not that way. So this was so here's what we asked them. Consider Mr. Davis, a 60-year-old man with persistent mild hypertension, systolic blood pressure 145 over 92. Exactly. Without pre-existing cardiovascular disease. He is adherent to lifestyle interventions and has no particular preference for treatment and wants your advice.
That's a good question. This is a great question because it's kind of a more common question.
It's
this
like
is the guy who,
primary care, right?
Yeah, right. This is bread and butter primary care from what I remember about it. But yeah, it is bread and butter primary care. Yeah. And so what you're saying here is that, wow, a lot of people really felt like, and what was the antihypertensive they could start? Lisinopril or amlodipine? What were they giving?
So we tried to minimize like a lot of the details that could make it easy to argue. So we said, what would you tell Mr. Davis is the chance that antihypertensive therapy will prevent him from having a cardiovascular event in the next 5 years?
That's a good.
So we just said antihypertensive therapy without giving specifics.
And what are you using for your answer? Using Sprint trial data? He's a little young for Sprint.
So I mean, so it's interesting because he wouldn't even qualify for Sprint because he's too low risk.
Right. Yeah.
So we did do like a literature review. There were no perfect trials because this guy's so low risk.
Yeah.
There were a few, and our estimate reflected that the relative risk reduction was like 0 to 30%.
Yeah, I
So
see that. So, I mean, that's, if anything, I'd say you're being generous, right? You're being generous in these estimates.
yeah. I mean, we were trying to be generous and trying to really peg it to literature we could reference. I mean, I think that probably there's a range, but including 0 was an important
Including
part of this
0.
one.
I think that's important to include. Yeah. And, to be honest with you, like, Dan, how often do you see somebody who's like this in terms of this blood pressure, but they're even younger? Let's say they're 40 or 30,
Uh,
and they're on antihypertensives. What are we hanging our hat on? I always wonder, like, what are we hanging our hat on, putting this person on 40 years of antihypertensives when they're
I'm, I think it's pathophysiological reasoning, right? I mean, the number will get better.
yeah, and
And
that's why on their way out you give them lisinopril and a cloth mask. It just makes sense. Just makes sense for that. Just makes sense. Um, so this is a fascinating thing. I mean, in your article, you argue that of all the errors being made, the more common error is that they're overestimating benefit. Is that fair to say?
yeah, I mean, so that was I think the primary takeaway from this is that across different scenarios that were common and relatively simple, that there was a significant overestimate. I think the median clinician reported benefit was 30 to 50% chance of benefiting a patient, when the scientific evidence was 1 to 3% chance of benefiting an individual patient.
Hmm.
And we argued that the other part that we found is we asked people, how likely would you be to treat a similar patient in your own practice? And doctors who thought things worked better tended to treat people in their own practice also, not surprisingly.
Not surprisingly. It's fascinating to me, Dan, because I mean, obviously, this and the other paper we're going to talk about in a second, super important. But we just don't talk about this in medical school. We teach people in a way that makes them think they're omnipotent. What are you really identifying? You're identifying like the doctor thinks they're omnipotent. This is the God, like the doctor thinks like I giving this pill can taketh away this risk. But the truth is the risk was low to begin with. And you giving the pill actually very modestly changes that risk, because most of what we do is modest marginal effect size stuff. But we teach people that they're omnipotent, and that's the explicit and implicit curriculum. Thoughts?
I mean, I think that's probably just something worth dwelling on. I agree completely, and I think it really shapes both how doctors are perceived in society. That gods, we can do these things. It's kind of the house MD, like figure out what's going on and then save somebody just with the power of your brain. Versus, and it's what we do with people when we make them leave the hospital, AMA, versus like, well, you could stay, it probably doesn't make a lot of difference either way. When that's the reality for a lot of the things we're doing, when somebody wants to go home to do something and we want them to stay, say, and it definitely is an overestimate of what we are giving to them versus what they are doing for themselves.
Yeah, we're like, it's safer to stay here because we're gonna watch you closely. I was like, I don't know about that always. Yeah.
Yeah. I mean, it may be, it may not. You may be taking a little risk, but it certainly seems like it's within the realm of reason to allow patients to do a lot more. And I think if you share these numbers with people, most of the patients I find who are capable of understanding them tend to say, "Oh, that's all? Well, no, I don't want to do it," or "Send me home," whatever.
Yeah, I agree with you wholeheartedly. And in addition to that, I find that like that to me is cancer screening in a nutshell. And also when you explain to somebody like that something improves progression-free survival or disease-free survival rather than overall survival quality of life, and they actually like start to understand like, well, what is disease-free survival? And you actually walk them through that, and then they look at you with this quizzical look, and they're like, why are your whole profession wasting your time with progression-free survival when you should be thinking about what I actually care about? I do find that. Let's talk about your first paper, but I'll call it your next paper. Accuracy of practitioner estimates of probability of diagnosis before and after. These two papers are such gems, Dan, and I think they're going to have a long legacy because I think they're super important. But walk us through this paper. I thought this was super interesting, and walk us through this.
Sure. I mean, that's flattering to hear them described that way. And certainly these were some of the hardest papers to do, just because these were surveys and we had to get doctors to complete these surveys that made them feel like they didn't know what the right answers were. which took a ton of work and just a lot of like personally showing up and sitting in the clinic until they're done type work. So, that's how you get a good response rate.
Yeah, you got to lean on them.
Yeah, I mean, there was a lot of social pressure, I think, that is not unethical, but certainly is the difference between people throwing it in the trash and actually completing it.
Yeah.
So we were trying to get at this idea of really just sort of how we make a diagnosis, which although we sort of talk about it, the art of medicine, that we form a list of different possible diagnoses, and we figure out how likely they are, and then we do some tests that modify that probability. It seems like we don't really ever apply that in real life, especially not in kind of a quantitative way. And there are these few studies out there where they've tried to sort of do this Bayesian adjustment to probability, where they've asked doctors, and doctors have been really bad at it. There's this classical one where they walked around Boston hospitals. I think the first one was in 1978, Cassell's, in a New England Journal letter. And they said, let's see, let me make sure I get the wording right. They say you do a test on a patient, and there's a 1 in 1,000 chance the patient has disease. The test has a
95%.
Yeah, 95% specificity. How likely is this is a positive to be a true positive? And most doctors say 95%. And the true answer is 1.96%.
Wow. Okay.
And then it was repeated in 2014 by Arjun.
Cassell, this is Christine Cassell's?
It's I'd have to look up the first name. I mean, it was published in 78, and it's someone who went to the NIH afterwards.
Okay. Go on.
Maybe a family member even.
Okay.
And then Arjun Man Ray repeated this in 2014 and got exactly the same answers. And it's really, there's a kind of two different answers. Either people just say 95% or people say kind of low. So it's either like they get the idea that like, oh, it's something less than this, or they just, I think, are frustrated and just kind of reach for the first number they hear, which is like probably 95% accurate.
Wow. Okay. Oh, I found it. It's Ward Cassell's Interpretation by Physicians of Clinical Laboratory Results, 1978. Wow. So this is a long-standing. I didn't really appreciate it. Went so back. So doctors have been blundering probabilities like this for a long time.
Yeah, I mean, we didn't really have tests in 1978, so it didn't matter. We had just a handful of tests. But obviously now, we do like, I think 14 billion tests a year in the United States. So, we are awash in test results.
When in doubt, test. So I guess what's interesting to me about your JAMA Internal Medicine paper is that, not only were there sort of pre-test probability assessments off, but even their post-test probability assessments were off. Like both are off. And if I were to quantify which direction, I guess people thought positive test results shifted your probability more than they in fact do. People thought that before the test, you had a higher probability of, before you got tested, they thought you had a higher probability of having the event or having the diagnosis than you did. And then after you got tested, they certainly thought you had a higher probability. And even negative test results, negative test results they were better about.
Yeah, no, I think that's a great summary that, it's probably like, 2 to 10 times higher estimates than reality.
Jesus.
For this. And
we watch too much House.
Yeah. I mean, I think we make diagnoses. That's what we do. We're doctors. The pretest probability part was a bit of a surprise to us. I mean, we were trying to figure out how you would study this, and we're like, well, if we're going to see how well they calculate the post-test probability, we need to know what the pretest is. And let's not just give them a set number, although it'd make it obvious how well they did the calculation, but let's ask them their estimate. Like, let's make this like real life. You see a kind of a simple patient, and how likely do you tell them they are to have a disease, and then you get a test in the results, and how likely are they to have disease after that test result?
Yeah.
So we kind of hid what we were asking, I guess. We weren't saying like, how well do you calculate, Bayesian adjustments? We were just saying, how likely are they to have disease, which, we think ultimately is what matters for doctors, but it's a much more complex process behind that simple phrase.
So correct me. All right. So I think these two papers are important, and they're going to have like a big contribution for how physicians reason about diagnosis and treatment. But let me put everything we've been talking about together in a single thing, and let's see how you feel about this. I mean, what are we talking about? We're talking about, like, we started by saying, I've gotten myself in a little bit of hot water by voicing some skepticism or acknowledging the lack of evidence for some policies, such as masking young children. You recently had a long tweet thread, which I think went viral, about how you were uncomfortable by calling this the pandemic of the unvaccinated, focusing all our energy on how they're such quote unquote bad people, unvaccinated people, and Biden has his plan to kind of increase vaccination rates. And then these two studies that show, well, doctors are much more likely to think they have the diagnosis. If it's positive, they are way overestimating, and then they think our treatments are working magnificently. And I guess to put it all together, I mean, I guess maybe what I would say is that, like, one of the persistent cognitive illusions that we have, pandemic and in regular day-to-day life, is that we just have so much more control over our destiny, and that our policies always work as intended, and they work marvelously, and they don't fail, and that they're not unintended consequences that offset our gains. But the reality is that these things are always true. And so, like, being a prudent clinician often means not ordering the test, especially because it can just take you it can take you to sort of a misleading probability, or being cautious about the treatments that have real side effects like antihypertensives do. I wonder if you see it similarly.
Yeah, I mean, I think that's a great summary of, I mean, I think just sort of my natural approach to things. And these two papers were ones that really, I don't know, I felt like they more than just sort of being in my normal line of work, they were ideas that seemed very interesting to me, and things I thought we missed. And so, yeah, I mean, I think that we way over assume, how much we know. There's not much openness to uncertainty. And it sort of leads to a thoughtless approach to medicine, and not the medicine that I want for me, and not the medicine I want for my loved ones or other people. And if we were, just a bit more aware of what we know and what we don't know, and and then being able to quantify that, then we could probably do less and get just as much from the the medicine and all the money and effort we spend doing medical care.
Somebody was telling me about this, like, weekly testing of kids in school or something, and they, like, are in a school district where it was happening, and this person was saying, like, look, I'm the reason I like it, this person's like, I like it because, like, after school, these kids, they have to be taken care of by, like, my, I don't know, grand aunt, or I forget who this person was, but some older person in their family was taking care of these kids. And they're like, it's nice to know that even though this older person's been vaccinated, that the kids have tested negative, so that we're keeping this older person safe. And I was like, what you've told me is a story that is compelling, but it is just a story. And the real question is, like, by having these kids give their little saliva once a week, are you really keeping this older person safe? And I guess here's some of the ways in which, like, it might not be true, which is that, like, this older person can get sick, not just from these kids, but from anybody in their life. Okay. So there's, like, so much of the world that's still uncontrolled in your model. The second thing is, the kid might test negative on Monday, but this older person taking care of him on Saturday. And in the meantime, something happened, and then the older person might feel falsely reassured by the Monday test and be all lovey-dovey. I mean, I don't know, maybe they're kissing and snuggling these kids more than they otherwise would had they had to live with the uncertainty. So their behavior might be different, risk compensation. And I guess at the end of the day, like, one could actually study this practice. Like, I mean, probably the older person daycare stuff, like, that would be harder to study, but you could just study, like, a randomized control trial of districts in which there's routine testing versus not routine testing. You couldn't use cases as the primary endpoint because the testing will have just way more cases, but you could use secondary endpoints, like how many teachers end up in the hospital or how many teachers end up, severely ill. And you could do a cluster randomized trial. And I guess, like, the challenge I had was this person wasn't in medicine, and it's very difficult to kind of explain to such a person that this thing that seems so plausible, like it ought to protect this older woman taking care of these kids, it could not work, and it could even backfire.
I mean, I agree completely. And there've been some estimates, like, people tried to model the effect of, like, weekly testing, because in nursing homes, this is one of the few things that we could do before the vaccine was around.
Right.
And it was very dependent on how long it took to get your test results back.
Right.
And how often you were testing. And I think they estimated that if you're doing twice a week testing, so like every 3.5 days, and you got your test results back within 48 hours, that maybe there's a 30% reduction. So
so that gives
in transmission, yeah. which even, which those realities are not often not the case. So, twice a week testing with a 2-day turnaround.
And I would say, and in addition to that, these are models based on assumptions. Like, it would be nice to empirically test the thing itself.
Yeah, it's probably not even accurate. Like, this is kind of like best case scenario in my mind. And sure, if you're in an emergency and you're just trying to make something work, but certainly, like, considering the downsides and doing the PCR testing, especially, I think is prone to the downsides of all these essentially clinical false positives from residual RNA.
I like to run it at 45 cycles. No, but yeah, I mean, I think this is the kind of stuff that, I don't know, Dan. I mean, I think, like, your papers are super interesting. And I feel bad in the sense that, like, I think about that kid who's starting med school now, and then, like, all the useless things they have to learn before they get to this stuff that's so important. And that, to be honest, when are we ever teaching these students this? I don't think we were ever teaching them this.
I mean, I steal an hour or two out of the curriculum and, and sort of talk to them this way, but I have a feeling that they're probably like, hey, remember that kooky professor? Like, remember he said that? Like, most of what we do doesn't work. Anyway, let's study the mechanisms of CAMP or something. I mean, and it is really disappointing, right? I mean, I think it's hard to balance the fact that you care about people and that you want the world to be a better place, but yet you don't believe that things work just because we think they work.
I think that's the hardest thing.
Yeah.
That's well put. That's the hardest thing in life, is to explain that when, I think that the goal is the same. Nobody wants this virus to kill people. And nobody wants life, and people want life to be maximally functional. Like, we all want the same thing. But the dispute is, like, is what we're doing getting there? Or is it at some point hurting us on the life side and not helping us on this side? And I don't know, there's something to be said for having been a student of medicine, because we know our limitations better than a lot of people. And I do think that people who are in engineering and computer science, they view the world differently. They're like, well, if I understand how it works, I ought to be able, that's all you need, because that's how this stupid laptop works, I guess. But the body ain't that way. We don't understand how the body works the way the laptop works. I don't understand how either work, but I know that somebody knows how this damn laptop works, but ain't nobody know how the body works.
Yeah, no, I mean, I definitely think there's, I do think just the idea that you've, obviously, espoused without even sort of standing back and sort of stating that it is a decision is, how do we know what we know? And I think Adam Rodman did a good podcast on this, like, talking about comparison theory from others. And I think it's pretty important. I think a lot of people don't actually say, like, oh, we actually need, like, clinical and ideally experimental data to figure out what works.
Yeah. Dan Morgan, this is terrific. 2 great papers. Great work. Very interesting stuff. I think people should read them. And thanks for doing this podcast.
Great talking with you, Vinay. Thanks.